action.
Okay guys, we're going to be talking about adhesive capsulitis. You might have heard of this being referred to as frozen shoulder. It's the same thing. Basically, the capsule around the glenohumeral joint is going to constrict. Adhesions are going to develop between the bursa and the capsule and the rotator cuff muscles. Basically, the patient is going to complain of pain in the shoulder at different times or through different phases. They'll complain of pain at different times. We'll talk about that. And then over time, they're going to lose range of motion and therefore lose function. Okay, so we're going to take these through each phase. The first phase is the most acute phase. This is the first 3 months of the inflammatory process. Usually your patient won't even come to therapy or even go to the doctor during this phase because they haven't lost any strength, and usually the only motion that they start to lose a little bit is external rotation. So they might notice, gee, my arm's a little bit stiff when I try to put on my coat, or maybe if I'm trying to reach back for my seatbelt, but it's not really limiting them yet, and they really only have discomfort when they do those motions. So usually just external rotation. It's usually not enough to get most people to think about it. They might, grab some Advil or something, or they might massage it, but they're really not going to go to the doctor usually, okay? When we in physical therapy usually see patients is in phase 2. That's called the freezing stage. So it's still an active inflammatory process, okay? So since it's an active inflammatory process, we can't stress these people out too much, okay? How are they going to present? My patient would be telling me that her shoulder hurts. Such a good actress. Her shoulder hurts with motion, but also at rest. So it's going to be maybe a sharp pain when she tries to use it, but otherwise just kind of a persistent ache all the time. Now she's noticing weakness, and now she's noticing loss of range of motion in all directions. Okay, she's going to present in the capsular pattern, which means that external rotation is going to be the most restricted, then abduction is going to be the next most restricted motion, and then internal rotation and flexion. I can't remember, I want to say Mansky says internal rotation is next and then flexion. Some resources you'll see those flip-flopped, and some resources you'll see that they are kind of jammed together and that internal rotation and flexion are limited the same amount. I see that change with patients, not that big of a deal, okay? So if I get my patient in the first phase, again, we hardly ever see anybody there. Active inflammatory process, you would do passive range, you would do active assisted range, they would be doing Codman's exercises, you would be doing joint moves, you would be doing some passive or active assisted stretching. You would teach the patient how to stretch themselves, again, in the pain-free range, or just kind of nudging where it starts to hurt. But again, they really haven't lost range of motion in that first phase, except for external rotation. We're going to start with the second phase because this is where we normally see people. So if you will lie down.
Oh, wait, on my stomach or on my back?
On your back, please. Thank you, ma'am. Okay. So I'm going to move your pillow just a little bit. So we'll say her right arm is the one that's bothering her. I certainly might do some joint moves in this case. And I showed you this on a skeleton, but now I have a real person. So if my cameraman will get right in here, I'm going to get right on the humeral head with the heel of my hand. I'm going to try to have her in an open packed position as much as I can. And I'm going to do some little 1s.
I felt things crack. It felt nice.
And 2s. Okay, active inflammatory condition. I don't want to stretch it. I don't want to go to 3s and 4s. Okay, I'm going to do some gentle long axis traction. This usually feels pretty good. They get very excited when we do this. And I might teach her, if you remember that one I showed you guys where you have the patient press down on the table and back up. It's just a little mobilization into inferior and posterior glide. I might teach her how to do that. Okay, we would definitely be doing some passive range of motion and active assisted motion. As much as I can, I want to maintain what she has as long as we possibly can. And she's losing motion in all directions. Okay, so we're going to be doing, okay, I'm going to help you raise your arm up. You tell me if it starts to hurt, and I can certainly kind of mobilize the scapula to try to keep it down. Okay, I would stop if I felt restriction. I might decide just to hold there. Again, I'm not pushing through the restriction, so it's not really a stretch. But again, it's kind of more maintenance. Okay, so I could hold 30 seconds. If she has pain before I feel restriction, I don't need to hold it. I would just go, okay, let me do that a little bit more slowly. Ask what hurt, where it hurt, all that kind of good stuff. Okay, I will do abduction. And if you use a short lever with these, it's much easier for you, because if I use a long lever, it gets weird. I have to do a lot of walking, but this way I can just shift my body weight. Okay, I can do internal and external rotation. Okay, this feels good if I give a little bit of a long axis traction first and then rotate. And again, I don't have her arm down here. I have her a little bit abducted, just to try to keep that open back packed position as much as I can. Okay, so I can do passive, I can do active assisted. I can start her with the submax isometrics. She is gonna love the Codmans because it's gonna give traction right there. Let's see, what haven't I said yet? Oh, okay, well, I've shown you this before. But I said active assisted, and I could teach her to do it herself. So if you hold on to both ends of this, and I want you to hold it like this. Yeah, that way your thumb is kind of facing up. You can hold it real good, okay? And I want you to go up this way. I always have my patients nice and slow, okay? Don't let it hurt. Nice and slow and controlled. Her good arm's helping her bad arm. But I have her go into external rotation, again, to clear that acromion. So as this capsule is shrinking up, and we have less and less space, I don't want to cause impingement, and that can certainly happen. Okay, so that's kind of the range of motion stuff. Patient, if you'll stand up. Okay, we can do, and I'm going to have you stand sideways, or actually just like that. Okay, and I'm going to have you put your thumbs up, and we're going to lift just as high as you can without pain in your shoulder, and then come back down nice and gently. Good. So I'm looking at the scapular stabilization. Keep going with that for me. Good. Okay, and I'm just going to show you guys, do it as slow as you can for me, please. Inferior angle. It's still there, it's still there. We're starting to move right now, and that's normal. She's about 80 degrees. Keep going nice and slow for me. And now this is her inferior angle. Okay,
I don't know how to respond.
Started out here and ended up over here. That's perfectly normal. It has to upwardly rotate when we get about 80, 90 degrees. So that's what I'm looking at. If, I'm gonna take your place for a second. Okay, if I had her doing scaption and what I saw was this, that's shoulder hiking and early upward rotation, I would have to bring her back down. Maybe we only do strengthening through this motion until we get that a little bit more solid. So if I need her to work her downward rotators and her retractors, I do. If it's just neuromuscular reeducation, I give tactile cues and try to get the right muscles to kick in at the right time. Okay? There's nothing wrong with strengthening right now. There's nothing wrong with her muscles. Okay, so if I see weakness, I can absolutely do some strengthening with hand weights or with TheraBand or anything we want. Okay? This isn't correct, but you get the idea. Only in the available range. Only in the range that she's not cheating. Only in the range that doesn't hurt. Only in the range that she's not compensating. okay? But you can do absolutely any muscle around the shoulder, no problem, okay? This phase is about month 3 to month 9 from the initial insult. The third phase is the really annoying phase. It is the frozen stage. At this stage, the active inflammation is gone, but now we have all the results. We have so many adhesions. So this is the time where we might have to get kind of aggressive with our mobes. This is when joint mobes 3 and 4 will come in. This is where aggressive stretching is going to happen. It hurts. Patients really aren't crazy about this. But if you warm them up and you've done a good job in phase 2 and we've kept at least some of the adhesions from forming, phase 3 will be a little bit easier. Okay. In this phase, the patient's only going to have pain with movement. The pain at rest, is going to be gone because it's not an active inflammatory phase anymore. We don't have active inflammation. We're going to keep going with exactly the same stuff. Okay, patient, if you will lie down here for me.
On my stomach or my back?
On your back, for now. Okay. So now, scoot towards me, please. All the way. Cool.
Like this?
Yep. Okay, so again, I'm going to get her in that opened pack position. Open pack position should look like she's in a sling. That's kind of the easy cheat to know if you're in a good position. And I usually just hold the arm like this. I don't want to grip, and if I catch myself gripping, I always just tuck my thumb in with my fingers so I'm not tempted. She should have a pretty good hold here. I could even have her kind of hold on to me a little bit if it makes her feel more confident, like she's not going to fall. But this is usually pretty good. Okay, so you might be doing grade 1 and grade 2s, and then you'd have the PT come over, and the PT is going to do 3s and 4s. And she has a really lax shoulder, so I'm not going to do that to her. Okay, inferior glide, trying to stretch out this inferior capsule, the posterior capsule. We could have her do the sleeper stretch. We're going to switch arms just so he can see it. I want you to roll onto that side for me. We're going to bring this arm just out like this, bend your elbow, and you're going to use this hand, and you're going to bring this arm down towards the table as far as you can.
This is as far as I can.
Okay, so she's a little bit tight, and I knew that on that shoulder. That's why that shoulder bothers you sometimes. So she would hold this as a sleeper stretch, 30 seconds to 60 seconds. We're trying to stretch the capsule. Capsular stretches we could do for 5 minutes, but usually people don't like to do this one for 5 minutes. So I'd have her do it 30 seconds to 60 seconds, but do it maybe 5 to 10 times, okay? Or maybe just stretch it out through the day that she does it more often, okay? Go ahead on your stomach for me. Okay, so we're back to this being the arm. Let's go ahead and put your arm off to the side, okay? We could certainly have her working her posterior deltoid and her retractors. I'm gonna have you do thumb up, and I just want you to lift up like that and down. I would give whatever overload is needed, whether it be the weight of her arm or a hand weight or a TheraBand. Okay, that's a T. Okay, this would be a Y. Lift up right there. Good. This would be an I. Lift up from there. And then we have the lovely W, which is going to be right here. And can you lift the whole arm up? Just like that. Okay, those are your I's, T's, I's, and W's. Okay, can certainly do those. We can continue with our against gravity exercises. Again, we're trying to keep away compensations. We're trying to strengthen through her available range, while through stretching, we're getting more range available. Okay, if I've been stretching her and before she could only go to here, but now she can go to here, she may not have strength in this new range of motion. So we've been working strength up to this point, but now she can go this far because we stretched out her capsule, but does she have the strength here? So I might have to do some multi-angle isometrics in her new available range, okay? You're always, hopefully your patient's changing week to week, and you're always looking for what they need, okay? Are they cheating in the new range? Okay, we got to put a stop to that. We got to go back to cueing the scapula, okay? Do they need assistance in the new range? Then we provide it, okay? Only once they're independent do we give overload, okay? Never make the mistake that if someone is cheating, oh, well, they need more strength, so I need to overload them. If they can't lift their arm, how are they going to lift their arm plus a weight? They're just going to cheat more, okay? So if someone can't do it on their own, back up the truck, okay? Regress it, okay? Get them the new skill, the new strength, the new range of motion, and then go forward again, okay? Let me see if I missed anything. This is our frozen stage. No, strengthen everything. You might be strengthening bicep and tricep at this point, everything. Stage 4, this is the thawing stage. They thaw from 15 months up to 24 months. So this whole process could take 2 years before someone feels like they have fairly good motion and function in their arm back. At this point, they should have minimal pain, probably only pain with very end range or difficult motions. We're still doing the same stuff we've been doing all along, but at this point, they should have range of motion approaching normal, or at least within functional limits. And we're trying to get them, hopefully now they have better strength, and now we can start mimicking more functional activities and just have them do more advanced things, okay? That's really it for adhesive capsulitis. If you've seen this in the clinic, you've probably seen a lot of really aggressive stretching, and unfortunately that may not have been appropriate when you were seeing it. If the patient still has the active inflammation, that's the last thing you want to be doing. So unfortunately, people, therapists, clinicians, not thinking about the timeline of tissue healing and what's actually going on in this process, sometimes we as PTs and PTAs actually bring the patient backwards instead of bringing them forward. So, but you guys are going to do better than that, right? Okay, we'll talk more about this later. Thank you.